This is a quick video on just some friendly advice around a massive hemorrhage and massive postpartum hemorrhage. And so, just yeah, up front, just a detail is we have some short form codes when ordering blood work. And so, for massive hemorrhage, we have this one called SANG, and it includes everything you need for a massive hemorrhage, including some clotting. Trying to think of them all: clotting, FSC, group screen, and cross match. Anyways, it's all there. And you just draw one blue, yellow, pink, lavender. And then ensure you have in an IV 18 gauge. And you're going to request for 2 units of blood on reserve. You would need to page the lab pretty much after 8 p.m. until 8 the next morning, but otherwise they're there. And just to keep in mind, like down south, we tend to be pretty relaxed, I would say, about ensuring when the placenta is delivered. Just keep in mind that the woman's risk of hemorrhage increases by 3 times according to the alarm course. Her risk of hemorrhage goes up by 3 times if the placenta is not delivered in 15 minutes. And so if you are waiting, you shouldn't be waiting passively. So if you've chosen physiologic management and not active management of third stage in at this birth, then at the 15-minute mark, you should be starting to take action. So emptying the uterus, but also getting ready that there could be more blood than is good or normal for this woman. So, our opinion is that active management of third stage is indicated when giving birth up north. Of course, that's a discussion for the woman, but in your recommendations to her, it should be that we recommend active management of third stage for all deliveries as it shows to decrease blood loss. So, if you have a hemorrhage unresponsive to therapy, of course, you're going to move through everything that we learned. So, tone, trauma, tissue, thrombin. And so, tone talks about the contraction of the uterus. So, the uterus can't contract well if there's something inside it. So, you want to empty the uterus of clots, you want to get the placenta out, and you want to install a Foley urinary catheter to empty the bladder. It's fine to do an in and out, but it's a drag when later on you're transferring the woman for monitoring in the department, or you're challenging her to be taken to Montreal, and then you have to go ahead and do a Foley afterwards. So, a Foley catheter, you put it in, you can take it out once she's stable. So if her uterus is empty, you can administer medication in this order. So we start with oxytocin, we add in misoprostol, then add in cyclocaprone or tranexamic acid or TXA, and then move on to your refrigerated ones, so ergot and hemabate. If you've got a 20-minute window where you're okay for waiting for the hemabate, and she can tolerate something by mouth, you can give the woman Imodium prior to giving her the hemabate. So 20 minutes before the hemabate, give her I think it's 1 pill of Imodium, and that just saves us from having like a crazy diarrheal incidents while we're also dealing with the massive hemorrhage. So if the uterus is not empty, then just use oxytocin through the IV bag, and you're going to do a manual removal of placenta, and I'll talk more about that at the bottom. So, in terms of trauma, we have in the maternity a hemorrhage kit, so a PPH kit. So, you want to ask for good lighting, lots of 4x4 compresses, the PPH kit, which we keep in the bottom drawer in the delivery room. And that has long ring forceps, a long needle driver, and forceps and retractors. And then put on your sterile gown, long non-sterile gloves, and a pair of sterile gloves, and start your assessment. And you're going to do it systematically, starting at the top, looking for trauma at the cervix, within the vaginal wall, along the perineum, and do a rectal exam. If you have never done assessment of trauma of the cervix, you should Google it. There's a systematic way of doing it, and you're basically walking along the cervix, and they explain it in the alarm course as well. For tissue, you're going to do like a manual, or I don't know, in French it's called revision of the uterus, but I think in English, we call it exploration of the uterus. So basically, she's bleeding, she stops bleeding, she's bleeding, she stops bleeding, she's bleeding, she stops bleeding. That's indication that there's something in the uterus. There's still perhaps remnant from the placenta. Perhaps you can see it clearly from the placenta itself that there's a bite out of it, or perhaps there were membranes. Usually they don't cause hemorrhage, but definitely a chunk of placenta will. So that's where you're going to get ready to do a revision of the uterus. So I would do a revision of the uterus before checking for trauma if the bleeding is on and off and on and off. So she starts up, her uterus fills with blood, you express the clots, she settles down, and then it starts up again. If it's a constant trickle, I'm thinking more trauma and thrombin. So, you can choose to move your assessments in a different order. In terms of thrombin, this is really rare, but we do have a lot of women, not a lot of women, maybe like, I'm guessing 5% of women in the Angava region with von Willebrand syndrome. Or the woman may be having a DIC, starting a DIC, disseminated intravascular coagulation. So we're going to order blood using our blue tube. We'll figure out her prothrombin time. But also, if you have the wherewithal, you can think of it. You can also draw up a red top tube and leave it at the bedside. And if it's not clotted in 7 minutes, it suggests a coagulopathy. Okay, so just some tips and tricks for uterine revision. So you want to have good pain coverage, and fentanyl is handy. Once you've done the procedure, it wears off in half an hour. She'll feel better. She can tuck in with her baby. She can breastfeed. Maybe she can get up to pee pretty soon after you've taken out the Foley. If she's not coping, if it's really overwhelming for her and you can't do a proper assessment because because the pain is too much, you can transfer the woman to the clinic where there's respiratory support, and with the help of a doctor and Versed and ketamine, you can have her, really experience full sedation. Usually, if you do the Versed first, talk about friendly thoughts, calm her down, then do the ketamine. You'll have a really good bit of coverage, anywhere from 15 minutes to 1 hour, however long you need to do the procedure, checking for trauma and doing a revision of the uterus. But you want to nurse at her head, checking for if she needs suctioning or if we need to move to respiratory support, as rare as that is. In a case where the uterus is now contracted, you've got all your medications going, but she's still kind of untrustworthy. She's still bleeding, stopping bleeding, bleeding, stopping bleeding. And you need to do a revision of the uterus. Perhaps at the moment you go in, you're waiting. The cervix isn't opening. You can't put your hand inside. You don't force your hand in. You can, the nurse can administer nitro, 2 pumps on the doctor's order. And so it's 2 pumps in her mouth. And just get ready, because that uterus is going to totally relax, and you can put your hand right up through her cervix and do a complete revision that way. Antibiotics aren't indicated unless there's a case of stillbirth, maternal fever, or she has other signs of chorioamnionitis, or if you think that she's symptomatic for clam or gono, she's been listed as a contact. But technically, for a uterine revision, all the texts say you don't need to provide antibiotics. So how do you do a revision? So just to review for those who know and those who don't know, this is some tricks that I do. And so with your left hand, you're going to put your hand on her belly and hold on to her fundus, the top of the uterus, and bring the uterus towards you. And with your sterile gloved hand, you're going to locate the cervix with your fingers. So you put your fingers inside her vagina, locate her cervix, and it should feel closed, like a bump, just like like a closed cervix when you do any other sort of vaginal exam. If it feels open, it feels open and floppy like the top of your sock. So if there was a sock hanging upside down and the opening to that sock, it's there. It's just this floppy circle that you're looking for. It all feels really mushy. It takes you a second to get your bearings. And then you're going to move your whole hand through the cervix into the uterus. And when the uterus contracts, it's like clamped down on your hand. You can hardly move it, but when it's relaxed, it's open, but then she's bleeding. So you just want to move kind of decisively and get it done, especially if the pain coverage isn't that good. One of the things to explain to the woman is, this is gonna hurt like hell, but if we work together, I can get it over with quicker. And if she's not tolerating it, stop, don't bother. You're not going to do a good assessment. Move on to better pain medication. So, when you get your hand inside her uterus, you want to basically systematically cover all areas. So, you just imagine the picture of the uterus. And so, go right up to the top of the fundus and start slicing your hand around the bottom of the uterus, keeping the tips of your fingers in the fundus. And you're looking for chunky bits of chicken. So the uterus feels like a steak. It feels like a beef steak, uncooked. And pieces of placenta feel slippery and smooth like a piece of raw chicken. And clots feel like clots. So you're just looking for stuff that don't feel like steak is basically the thing. So you've got your fingertips, you're moving around the whole uterus from back, top, and sides, and then to hurt the anterior part. So you just keep moving around, covering the whole area. Once you get your palm full of stuff, clots or pieces of placenta, you take it out, you drag it out in your hand, and you go back in. And you do it however many number of times it takes to clean out the whole uterus. So perhaps it takes 3 times. So the first time you find that bit of placenta, the second time you're drawing out some more clots, and the third time you go in and you feel absolutely nothing else other than just a piece of raw steak, which is the inside of the uterus.